Assalamualaikum and good afternoon. Today I'll be presenting a research on cadaveric investigation of the minimum effective volume for ultrasound-guided suprainguinal fascia iliaca block. This is the original research done by Faculty of Medicine, Chiang Mai, which was received in February 2021 and further revised in March 2021 and subsequently published in BMJ in 28th of April 2021. So the outline of my presentation will be introduction, materials and methods, the results, and finally the discussion. For introduction, regarding fascia iliaca block, it was first described in 2011. The ultrasound-guided suprainguinal fascia iliaca block targets the fascia iliaca compartment cephalic to the inguinal ligament. Suprainguinal fascia iliaca block could potentially anesthetize the femoral and lateral femoral cutaneous nerve and also obturator nerve. So successful block of the femoral, lateral femoral cutaneous and obturator nerve depends on the injected volume. So this cadaveric dose finding study, they investigated the minimum effective volume of dye in 90% of cases, denoted as MEV 90. That required to stain the femoral, lateral femoral cutaneous and obturator nerve for ultrasound-guided suprainguinal block. So going into materials and methods, they used all fresh adult human cadavers which were donated to the Department of Anatomy of Chiang Mai University. So these cadavers with previous hip surgery or surgery in the inguinal area, they were excluded from the current trial. Regarding block performance, there will be a single investigator who perform all the blocks. Cadavers were placed in the supine position. Prior to obtaining the ultrasound image, the first site to be blocked, which was left or right, was assigned according to a computer-generated random list. So they used a linear ultrasound transducer in a parasagittal orientation, medial to the anterior-superior iliac spine in order to obtain the bow tie sign. So they identified the sartorius, iliacus, and internal oblique muscles. So this is the image that they can see through the ultrasound by using this method. Subsequently, using an in-plane technique from caudate to cephalic direction, they advanced the tip of the needle. They use stimoplex needle between the internal oblique and the iliacus muscle. Which is underneath the fascia iliaca. They use the dye which is 0.1% of methylene blue. So the volume of dye administered through the block needle was determined according to the up and down sequential method. I'll explain about this in my subsequent slides. So in order to minimize wastage of cadaveric leaks, ultrasound-guided suprainguinal block was also performed on the contralateral side. But they used the identical volume of dye compared to the previous, the other side. So cadaveric dissection and definition of block success. 1 hour after the end of dye injection, cadaver was dissected. All dissections were carried out by the same two investigators. They worked together and the volume administered was blinded. So the skin incision was made to expose the entire abdomen, both inguinal regions and anterior aspects of the upper thigh. The anterior abdominal wall, stomach, intestine were completely removed. And for the first site injected with dye, fascia iliaca over the iliopsoas muscle was carefully dissected. They exposed the femoral and lateral femoral cutaneous nerve. So to find the obturator nerve and the lumbar plexus, psoas muscle was retracted laterally. If the femoral, lateral femoral cutaneous nerve and obturator nerve were stained with dye, so the block was considered a success. If one of these three nerves was not stained, so the block is said to be a failed block. So this figure shows a dye staining pattern of the obturator nerve. So in the first figure, which is the A on the left side, in this pattern, the dye stained the obturator nerve only at the posterior medial aspect of the psoas muscle. Whereas on the B side, on the right side, the dye stained the obturator nerve posterior-medial to the psoas muscle, as well as inside the retroperitoneal compartment. So this is an example of block failure, where we can see the femoral and lateral femoral cutaneous were stained, but the obturator nerve was not stained. So, in the event of a successful block, an envelope containing the volume assigned for the next cadaveric leg was opened. So if the next assigned volume was the same as the previous injection, fascia iliaca was dissected in order to record the staining of the three nerves. However, if the next volume of dye contained a 2.5 ml decrement, dissection was not undertaken. So similarly, in the event of block failure, contralateral lower limb was not dissected, as depicted in this diagram. So if the first site is a successful block, so they open the next envelope. So the next envelope contained the randomized volume of the dye open. If the volume is the same as the initial injected volume, they will dissect the contralateral site. But if the next volume shows a decrement from the previous volume, they will not dissect further the contralateral site. Same as the failed block. So going into volume assignment according to the BCD and sample size estimation. So the volume used in the first cadaver and both cadaveric legs was 40 mils. They started with 40 mils. So subsequently, volume assigned was based on the response. In case of block failure, they will increase the next injected volume by 2.5 mils. But if it was a success, then they decrease the volume by 2.5 mils as well. And there was no maximum threshold volume in this study. So the results, the study took place over a period of 5 months. They did it over July, from July 2020 to November 2020. Of which they found 36 cadavers and also 60 cadaveric specimens of the lower limb were dissected. So in order to open the 45 randomization envelopes, bilateral dissection was performed in 24 cadavers. The minimum effective volume was found out to be 62.5 mils. In all cadaveric specimens dissected, the femoral and lateral femorocutaneous nerve were stained with dye. Thus, the block success or failure depends solely on the ability of the dye to reach the obturator nerve. So, in all 46 instances of successful obturator block, dye stained the obturator nerve in the posterior medial aspect of the psoas muscle. Then, discussion. The minimum effective volume in 90% of the study reported in this study deserve a special mention because they said it exceeds the 40 mils volume commonly used for the hip surgery. This owes to various factors. Number one, cadavers inherently differ from live patients in terms of the diffusion of the dye or local anesthetic. And this dye and local anesthetic spread may not be identical due to differences in intrinsic viscosity and density. So the minimum effective volume represents the volume required for 90% of subject. Sometimes the lower volume, example 50% of subject, could still be clinically effective. So they postulate several mechanisms underlying obturator nerve block with suprainguinal fascia iliaca block. The first one, it could be due to cranial spread of the local anesthetic. So obturator nerve is found posterior medial to the psoas muscle. So anterior fascia iliaca compartment, which is positioned ventral to the psoas muscle, to a posterior one, which is dorsal to the psoas muscle. So another thing is local anesthetic migration from the fascia iliaca compartment to the retroperitoneum, where the obturator nerve can be found near the iliac vessels. So the limitations of this research include they did not assess the dye spread to the accessory obturator nerve. And the minimum effective volume reported in the current trial cannot be dissociated from the definition of block success. And it's pertained solely to the volume of dye because they did not study the viscosity and of the solution. A bit on course of the obturator nerve. The obturator nerve originates from the anterior rami of spinal nerves of L2, L3 and L4 of lumbar plexus from the psoas compartment. Then subsequently it exits the psoas compartment and it enters the retro-psoas compartment at the posterior medial margin of the psoas major muscle. Then it enters the fatty retroperitoneal compartment by invaginating the fascia transversalis. And it exits via the obturator canal by invaginating the deep pelvic fascia. So, while the fascia iliaca compartment is a space between the anterior surface of the iliopsoas muscle and the fascia iliaca contains the femoral nerve, lateral femoral cutaneous nerve and the genitofemoral nerve, but not the obturator nerve. So, by right, an injectate needs to spread outside the fascia iliaca compartment in order to reach the obturator nerve. Anatomically, it indicates that fascia iliaca compartment block is unlikely to block the obturator nerve unless an artificial passageway is created by intervention. So, as we can see here, the fascia iliaca is denoted by this green line. Macam ni. Jadi when we block the fascia iliaca compartment, we block the lateral femoral cutaneous nerve and the facial nerve. Sorry, femoral nerve. Tetapi and also genitofemoral nerve. But we did not reach the obturator nerve which lies outside the sheath. Gitu Doktor yang saya dapat daripada research ini. Thank you.